much for participating. And thank you for joining us today for our webinar, CMS Revenue Management and Risk Adjustment Using Data and AI. My name is Lauren Fouts. I am the Director of Corporate Operations at Bloom Value. Just a little bit about Bloom Value. We are an AI enterprise platform company offering a wide range of AI-driven solutions and services for healthcare organizations. By using augmented intelligence and machine learning, we're able to give our clients unprecedented visibility and insights into their businesses. So users can see how all areas of their organizations are impacted by various factors, which allows them to make proactive decisions with confidence. Our AI solutions serve hospitals and health systems, as well as health plans and risk-bearing organizations. You can find more about our solutions and connect with us at bloomvalue.com. As far as today's webinar, we are especially focused on risk-bearing organizations and leveraging AI to help them solve complex problems. Today's theme is risk adjustment and CMS revenue. We've gathered together some experts who have decades worth of experience in both AI and healthcare management, and they're hopefully going to help you address some of the pain points that you're facing in your organizations. I know from experience that our experts could speak for hours on the topic, but we're going to try to avoid that. And so we encourage you to ask questions in the Q&A tab as well as the chat, and we'll be monitoring those throughout this webinar. Also, let us know what questions you have and what things you'd like to explore in the future with our future webinars. And finally, if you would like to set up a call, a one-on-one call with no cost to you with one of our experts to discuss your specific needs, please feel free to add in the chat something on the lines of, I'd like to speak with an expert or one-on-one, and I'll take care of connecting you after the webinar. And with that, I will turn it over to Jared Turley, who will be leading the conversation with our experts. Jared?
Yeah, thank you, Lauren. So I'd just like to do a quick introduction. My name is Jared Turley. I've worked in the healthcare in California for 10 years. I've worked in restricted Knox-Keene licenses, full Knox-Keene licenses, working for managed service organizations in healthcare for about a decade now. I've worked as a CFO, and currently that is my role. We have about 100,000 lives that we have under management, and it's great to be here today. With the panelists that I have with me today, I have Christina Valenzuela, Wes Stevenson, and Arun Hampapur. We're so excited for each of them to be with us here today. I'm going to leave some time for them to introduce themselves, and we'll start with Christina. Christina, would you like to do a quick introduction for yourself?
Yeah, thank you, Jared. Good morning, everybody. My name is Christina Valenzuela. I'm a certified professional coder with over 20 years of experience. I also hold my CRC and CDEO certifications for risk coding and as a documentation expert for outpatient services.
Yeah, so Christina, how did you come across coding?
Yeah, that's always interesting, right? So my healthcare career actually started with a billing position at a private company while I was in college. I was introduced to CPT and ICD coding systems. It was during this time that I actually understood the critical role of this language, per se, in ensuring accurate payment for services and effectively communicating patient diagnosis information throughout the healthcare system for patient care. I pursued my interest in billing with a role at Loma Linda University Healthcare, where one of my responsibilities was serving as a billing liaison between the pediatric and billing departments. In this role, I collaborated with providers to ensure compliant documentation and accurate coding practices. And that's where I became a certified professional coder. More recently, I've spent the last 18 years with Promise Care Medical Group, where I played a pivotal role in developing a comprehensive risk adjustment program for both retrospective and concurrent coding initiatives and provider education and training, significantly contributing to revenue growth.
Wonderful. Okay, Wes. Wes, you're on mute.
Somebody has to do that. Every time somebody has to do it in our modern technology. I'm an EVP of risk management. For the past 30 years, I've been working with multiple organizations. Currently, my main focus is in the risk adjustment area. I have an MBA in healthcare management. I have a BS in accounting. I am a certified corporate financial planning and analysis professional. I have my FPAC certification. I've been working in computer programming and numbers for over 50 years. My primary responsibility right now has been in the risk program and the risk adjusted program, including all the things to do with profitability, reporting, coordination. I've had multiple positions in the organizations, mainly on the IPA side. I've been an IPA administrator, I've been a hospital liaison, a practice administrator, worked with accounting. So I've done every piece of work on the IPA side that we can do.
Yeah, thank you, Wes. And I've worked with you for many, many years. I've learned so much from you and very excited to have you on this panel. Arun, would like to have you introduce yourself. We're very excited to hear from you today.
Hey, thank you, Jared, and it's really nice to be on this panel. So my name is Arun Hampapur. I'm one of the co-founders and the CEO of Bloom Value, and Bloom Value is all about optimizing the finance and operations of healthcare enterprises, and that, Jared, as you know, is a data-heavy task. And prior to starting Bloom, I was with IBM for 23 years, mainly in the research division. I basically worked with a lot of the most advanced researchers in AI and data analytics before it became popular. And we launched several products into different industry sectors in IBM. So, and I guess I'm one of the one of the earlier people in this AI business. I got my PhD in AI from the University of Michigan much before it became fashionable to use the word AI in the market, if you will.
Yeah, an absolute guru when it comes to AI. But Arun, so you worked for IBM for 23 years. Why did you leave IBM to start Bloom Value?
It's a great question, Jared. I have a few guesses to the answer. I'm not sure the exact answer. At IBM, I really had the opportunity to sit with big organizations in different sectors and see how they could use data to optimize their businesses and enterprises, often leading to better operations and profits, whether it was retail or homeland security. I suppose when the pandemic hit, I was part of the Great Resignation. I said, "Am I doing what I'm supposed? Am I working on what I'm supposed to be working? Is this the right thing?" So on and so forth. Those questions popped up. Turns out my wife is a physician, so that possibly had something to do with it. And all that put together, I said, "Why don't I go take all this enterprise optimization knowledge and apply it to healthcare?" Which surprised me was such a low margin business. One would imagine that given the amount of money we spend on healthcare in this country, that healthcare enterprises should be having a healthy margin, but it turns out that isn't the case. So I was a perfect fit for what I knew, and that's what Bloom's about.
Yes, an incredible career, and we're so excited to be able to pick your brain a little bit today on how AI is now transitioning into healthcare, which has typically been an industry that is very slow to adopt a lot of new technologies in some ways, not as much as in others. But we want to dive right in and get into more of the topics of why we're doing this webinar today, and that is risk adjustment. So Christina, I want to start with you and ask you the simple question: what is risk adjustment?
Yeah, thanks, Jared. So, like you stated, right, a simple definition for risk adjustment in healthcare. It's used in payment models really to align reimbursement with a patient's health status. Since populations with more chronic and acute conditions generally incur higher healthcare costs, risk adjustment utilizes ICD coding to provide data required to support these costs. It's essential for us to ensure that providers code to the highest level of specificity and accuracy to secure appropriate payment for patient care.
Yeah, so it's not a static model, right? But so does risk adjustment models change year over year?
So yes and no, right? The premise behind risk adjustment is the same. We're aligning reimbursement with patient care, but guidelines change. ICD codes that risk adjust will potentially change year over year. So it's our responsibility as coders and the risk adjustment team to stay up to date with these changes.
Yeah, thank you. So that's the perfect overview on how we want to start this out. And I want to direct this next to Wes, because Wes, in what you've currently been doing over the past number of years, is working on the risk adjustment, particularly with revenue from an RBO's perspective. So how does risk adjustment impact an RBO's revenue?
Definitely impacts it a lot. And really, I want to explain what makes up the revenue or the risk adjusted. On average, CMS wants everybody to be a 1.0. So across the whole nation, from Florida to New York to Washington, Texas, California, it really doesn't matter. If you're in this risk adjusted market, CMS is taking everybody nationwide and making everybody a 1. They want a 1.0 to be average. Okay. One of the things you have to understand is to get that number of 1.0, you got to take the demographic portion, which is made up of the age, gender, whether or not they are full risk, they're part of the Medi-Cal population, they're a new enrollee, all those things. Demographic doesn't really do much. So really a lot of the things that I concentrate on all the time is the physician component, a RAF score. From a 1.0, let's assume in all of our things that we're going to be talking about, we use $1,000. Great number, just a round number that we can use. For an average Medicare Advantage, an MA member over 65, the demographics on average are about a 0.5. The rest of your score is based upon the physician RAF. So if you have just the average thing, you get 0.5 or you get $500 of your global. So everything I'm going to talk about is beyond that. I don't care about the demographics. It is what it is there. I can't touch that. I can't change it. I can't impact the demographic portion of it. So we're going to talk about the physician part of it. So for instance, if I have an MA member, average member, who has diabetes without complications, and they're also COPD, my RAF score will be a 0.94. Of that, the 0.5 is the demographics. So the physician component of everything is a 0.44. If I take that average global amount of $1,000, it means I get $440 per member per month. If I take 12 months and I just take 1,000 members, those 1,000 patients will equal $5.28 million extra per year. If you don't code those, you don't get that coding, you lose that $5.2 million. That's a lot of money. So we have to make sure that we are getting all the codes we need to, because it highly impacts what the RBO revenue we get.
Yeah, and I think it's important to note that when you're doing this type of work for any physician, everything based off of the current risk adjustment model is reset every year. So Wes, in your own organization and in your own work, how are you tracking the need for these HCC codes to be recaptured year over year?
You're exactly right, Jared. It does reset. We joke about it a little bit that, hey, every person who can breathe great and wonderful now at the first of the year, they might have had COPD, but they're great. They're wonderful. They're marathon runners. Somebody who had an amputation, that grows back until you code it. It's a crazy system. Not everybody agrees with how CMS does it, but that is how CMS does it. They control this. The health plans control what it is there. So we actually take large databases. We take all the information from prior years. You have to put them into a large database. You got to use some sort of AI, some sort of machine learning, some sort of data aggregator to collate this data, making sure that you can get those patients in year over year over year. If you don't do it, you will miss patients. You will have things slip through the cracks, which will reduce your revenue.
Yeah, so risk adjustment is not limited to Medicare Advantage, because a lot of people think that, if you're in just Medicare Advantage or you don't have those types of lives, that risk adjustment doesn't apply to you. But are there other programs that require risk adjustment?
Oh, that's a great question, because most people do believe that Medicare Advantage members are the only people that risk adjusted is concerned with. In fact, that's far from the truth. CMS Original Medicare has stated that they're going to start using, or they plan on using, some sort of RAF modifier. People that have higher codes or higher amounts will get extra dollars for them. ACOs currently use RAF scores. It's currently RAF. It's what happens this year, but they do use RAF scores to adjust it. In California, we are actually now seeing commercial plans that are introducing RAF scores. In fact, Medi-Cal and Medicaid, the last refuge of all these things, have stated probably by 2030 or so, they plan on using some sort of RAF score. This allows the health plans, the organizations, the government to help control costs and make sure that the patients are getting the best care or the highest quality care, or passing the dollars to those people that need to use it more. But everybody's going to be using it over the next 10 years.
Yeah, thank you, Christina and Wes. That's a great introduction to where we want to start pivoting to, which is how AI is going to start changing the industry. And we'll pivot the next question to Arun. But before that, we want to put up a survey for all the participants that are here today. We want to know a little bit more about what risk adjustment programs you use, or if there is something that you use outside of what's here. Or if you'd like to comment, we'd love to hear some of your questions or comments in the chats. We will read it and address it. So if you could please respond to that survey, we would love everybody's participation. And while you're looking at that question and responding, I'd like to start pivoting towards Arun on how AI helps with risk adjustment. So Arun, do you want to tackle that here?
Yeah, absolutely, Jared. So if you play the word association game, and somebody says AI to me, the immediate word that pops out of my mouth is data. So AI, data analytics, machine learning, there are many different technologies that broadly can be grouped under the AI umbrella. And all of them essentially deal with data. How do you make sense out of data? Right? That's fundamentally what AI is in a nutshell. Now let's switch gears and talk about what Christina and her team need to do. So risk coders, maybe we could change their title and say needle in the haystack finders, because that's really what they have to do for a living. And I wanted to put this in perspective, so I did some research on this. So it turns out that an average medical record has 80 megabytes of data in it, right? And if you translated that into notes and lab reports and so on and so forth, within a year, it could be a 60 to 100 pages of notes. That's like a pretty intense book, because everything in there is medical lingo. Like if you look at the background picture, I'm not a physician, so most of the words in there don't make much sense to me. But I suppose Christina has studied for it and can actually decipher it. But that's just the beginning of the puzzle. So what I realized is, well, in order to be able to find and document an HCC code, the risk coder has to go into the medical record, look for specific conditions, and each condition is then coded up into an ICD code. There are 70,000 of those, but sometimes the condition may not be mentioned in the record, but just the procedure might be. So they have to infer the condition. I'll throw in another 70,000 codes in there. And then it's just not that, but not all these 70,000 or 140,000 codes map into HCCs. So, if you solve one of those giant puzzles where there are 1,000 pieces and you've got to put it all together to make that picture, well, that's really what a risk coder is doing, because you need to take those medical record evidence, turn it into an ICD code, and then plug it into an HCC code. And while that is an intense task, and excellent coders can do that, that is a challenge, right? And this is exactly where AI can help. So broadly, there's natural language processing technology, and these days the evolution of that is called large language models. So these models can be applied to read the EMR. So taking that example of a risk-bearing organization with 1,000 members, so instead of actually going and looking through 1,000 charts for coding morbid obesity, Christina could go to the AI tool, and it would have already gone through the 1,000 charts and listed out the 100 that possibly are candidates for morbid obesity. And then the risk coder looks into those and confirms what the machine is saying, and then formulates the code. So this is, I'd say, what is at the heart of matter of risk adjustment and coding, but there's many other adjacent use cases of how AI and data can help.
Yeah, I appreciate that. And we actually had a question come in that I'd like to address with Christina, and that is, if patients have been optimally coded for risk adjustment, are there other gaps in the process that could impact the actual capture of the anticipated revenue? Great question.
Yeah, great question. And yes, absolutely. Compliance, right? We want to make sure that at the end of the day, codes can be coded, right? Diagnoses can be coded by our providers, but ultimately, we're going to be audited, whether it's by CMS or health plans or whichever organization that we are reporting to, right? So we want to make sure at the end of the day that our coding is supported by the documentation by our providers. So yes, we can get it out there and maybe get the revenue in, but eventually when they come back and audit us, they'll take it back. So great question, but there's always room for improvement for sure.
Yeah, so Christina, Arun mentioned some aspects of AI and how AI is coming directly into your line of work. So how do you think the use of AI is going to impact your risk coding team?
Yeah, great question. I think, first of all, I think the biggest misconception is that AI will replace coders, but I don't believe that. In reality, it's just going to change the way we audit. So
Okay.
risk adjustment auditing is a manual and labor-intensive process, and I chuckle because that's what Arun stated a little bit ago, and he's right, right? Particularly when we're dealing with large IPAs and thousands of lives. Given the scale, errors are inevitable, and as many of you are aware, the Office of Inspector General is actively searching for those mistakes. In a recent report, an organization was audited by the OIG and found that 226 of the 275 member audits conducted, they had diagnoses that were not supported. So it goes back to your question that I answered just a little bit ago. Now they're being asked to pay over $500,000 in incorrect payments. AI can assist by identifying gaps in real time, prompting coders to review and validate those issues as they occur. The technology not only reduces the time required to audit charts in a compliant manner, but it also boosts my team's efficiency, and the organization's overall success. Most importantly, AI allows for more frequent audits throughout the year, helping to keep up with potential compliance triggers and patient utilization. By identifying issues in real time, AI ultimately enhances patient care and their outcomes.
Christina, actually, that's a fascinating thing from me dealing with numbers and trying to make sure we get the best revenue in there, is the AI and how we do things and making sure that we have proper documentation. For instance, what we have found is you have somebody who has diabetes without complications. Pretty easy. We get them in there, we see them, and you get a 0.105 for that person with complications. But if we can, through AI, through additional information, through looking at the charts that is properly coded and making sure that the documentation is there, because that's key. Otherwise, CMS or whoever will take that money back. But we can get that diabetes with complications. Diabetes with complications of 0.302. Again, back to my original example is I'm just looking at the physician's component of the RAF score. The difference between a 0.105 and the 0.302 is a 0.197. I know it's a lot of numbers, but being an accountant, worrying about revenue, these are things that are super important to me for the organization. So I get that 0.197 times my $1,000 global rate is $197 per member per month. So if I go with my 12 months and my 1,000 members, go back to those 1,000 members, that's $2.364 million extra just by making sure that I'm coding to the highest level of specificity and making sure that I'm documented for all of these extra complications. Again, from an ACO perspective, anybody that's dealing with an ACO, you got to be very careful, because if a doctor codes, they only get one time to code. That's all they get. CMS only takes the original encounter. And they only code for diabetes without complication. And you got 1,000 lives, and those 1,000 lives should have been diabetes with complication. You just lost $2.4 million. You can't get that back. There's nothing you can do on it unless you bring the patient back in there. And if you're not tracking this through some sort of program, through some sort of AI, through some sort of master database, you won't even know that you don't get it. And remember, there's a long time frame. So somebody that comes in January, you might not see the additional money that you do until the following January. It could be a year later based upon when things were submitted. So to understand what you need, how you need it, and making sure that you get all the documentation done when they need to do, it's so important to have all of that information done all the time and making sure that you are tracking it.
Yeah, thank you, Wes. I appreciate you getting into the numbers because as a finance guy, that's exactly where I want to be. That's my comfort level. So, Bloom, it's so exciting to see where they're going and how they're changing some of the way we've been looking at things. And Bloom, we're focused on risk adjustment, but Bloom is working with hospital clients, with larger health system clients, and we're just focusing on this single risk adjustment. But Arun, while we have this focus and this fine-tooth comb that we're going through on how AI is in risk adjustment, can you elaborate a little bit on the touch points for AI in risk adjustment and a little beyond?
Indeed, indeed, Jared. So this, if you start on the top left of this chart, so we spent quite a bit of time talking about how risk adjustment is a data-intensive process and how AI can help. But just putting the codes, finding the codes from the chart isn't the end of the story. It's just the beginning, right? Like Christina mentioned, there's compliance. And just imagine that CMS or AIG comes to our organization and says, okay, you guys claimed, 0.3 RAF increase for these 50 patients 3 years back or 4 years back. Show me how you got that. That isn't an easy question to answer, and it basically, when you think about compliance as an area that risk-bearing organizations need to deal with, organizing and managing your data and being able to find the right piece of data at the right time is an application of analytics and AI and visualization, if you will. And that's kind of how we use the term AI at Bloom. It's not just necessarily large language models, which is what's currently the buzz in the industry. So compliance could be an area, and think about care quality. Identifying which patients need to be brought in to the physician's office today is again a data problem. And moving on, wherever there's data, there's typically errors. And the worst kind of error for an RBO, of course, is in patient data, but if the payer has errors in their data, you're possibly getting the wrong revenue. So how do you catch those? And stepping back, if you think about why we're doing risk adjustment and why is CMS in place, it's all about bending the cost curve while maintaining quality. So reducing cost and managing cost is a big, big challenge. And that, again, is dependent on data. So if you look at the middle row of things there, things like how do you identify which high cost procedures are being overused? For example, there's a lot of GLP-1 that's being used these days, and that tends to be a very expensive medication. And it turns out that the best practice for using that, there's a certain protocol, and not every provider may be following that protocol. So how do you find those among your thousands of patients and thousands of providers, if you will? Finally, I'll wrap with these couple of things. So we've built something called the Smart Authorization Engine, which automatically approves prior auths. And when you think about prior auths, we've all been in this situation where you went to the doctor, your primary care provider, and the primary care provider said, get an MRI, go see a physical therapist, and that triggers a prior auth to the insurance company. And sometimes it could be days and weeks before they approve your request. With AI, we're able to turn that and reduce the turnaround time to literally minutes. That it helps with patient satisfaction and provider satisfaction. And finally, I'll wrap with what we would all agree is the holy grail of healthcare, which is treating the patient before they fall sick, right? So predictive care, proactive care is where we all want to be so that we can intervene before somebody goes to the emergency room, if you will. And that in itself is really a predictive modeling problem or an AI problem, if you will. And all of the data that we deal with in risk-bearing organizations can actually contribute to that very effectively. So all the way from compliance to predictive care. Data analytics and AI have a big role, if you will.
Yeah, and Arun, 23 years at IBM is an illustrious career, and working with so much data with different industries within IBM. Uh, how do you compare healthcare and its data and needs and where it sits at its core to other industries?
It's a great question, Jared, and it took me a while to figure out how to answer something like that because prior to Bloom, I was working in the retail industry, right? And as you can imagine, on Black Fridays, actually the entire country is on on retailer website and it's scrolling through different offers and so on and so forth. And all that data is actually being mined, so you can actually make the right offer to me the day after Black Friday, so that I can buy the right coffee maker or so on and so forth. But when you look at that data, the volume tends to be huge in retail and many other places. But well, if you don't recommend the right coffee maker to me, it's not the end of the world. Well, you switch to healthcare and you start looking at EMR data and then ICD code data. Well, if you miscode by a single digit, it means something vastly different. And well, when the diagnosis is different, the treatment can go off in a very different direction. So what I realized is that the meaning or the semantics and the depth attached to each byte of healthcare data is vastly different from many, many other industries, whether you think about it as retail, homeland security, or manufacturing. It just has a fundamentally different implication when you think about each byte of data. So how you assemble the data, how you interpret it, and how our machines do that, you just have to exercise quite a different type of technical talent to deal with healthcare data, if you will.
We could literally spend an entire day just with Arun asking questions back and forth, but we only have these 60 minutes, and I want to just talk a little bit about healthcare and how it's constantly evolving. And one of the examples I have is, V24 to V28, and those models are constantly changing. So what does a physician or provider, and this is to Christina, need to do differently
Great question.
as it's evolving?
Sorry, Jared. I know
No, you're
that's
good.
a great question. From a coding perspective, healthcare's honestly should just strive to code conditions to the highest level of specificity. I think we've said that quite a few times, right? And honestly, putting focus on ensuring their documentation supports those conditions. And I think maybe even the most important part, obviously, is ensuring patients' overall health, right? So as coders, it's our responsibility to educate them about the risk adjustment payment models and those coding guidelines. This helps them understand how their documentation and coding practices actually affect the funding available for ongoing patient care that they're requesting for their patients. So by leveraging AI and working with the risk adjustment team, providers can concentrate on patient care, while we support them with the necessary resources and training to ensure compliance and proper funding, regardless of any future CMS model changes.
Yeah, and Christina, physicians have so much that they have to do in this single, 40-minute or less visit usually. So as you're doing these trainings with these physicians, what's usually the feedback that you're getting when you do that just initial contact and that initial training with a physician on this risk adjustment work?
Yeah, so one of the things that I explain to most providers when I meet with them, when I'm going to audit their charts, is here's the thing, they're already treating and monitoring all of these chronic conditions a patient has. The missing link is that they're not necessarily assessing them on in the note, right? So we help identify those gaps for them and ensure that funding comes in to take care of those patients.
Yeah, they're addressing the acute need, and it's very critical to get, like we talked about with Wes earlier, that because these drop off every year, the patient, according to CMS, is suddenly healthy. And that's obviously not the case. And so in order to maximize that revenue and get the dollar that you need to pay for that care, it's a critical step. So, Arun also explained how AI can help with risk adjustment. So Wes, where else do you use AI in the context of a risk-bearing organization?
Yeah, there is so many areas that we do it. In fact, when we're looking at risk management we use data aggregation for the data analysis. We use partly for the natural learning processing, machine learning, all those fit into the AI. But I want to go back to a question that somebody asked earlier about data and how we get the codes off to the health plans and what can interrupt all those processes. Christina covered part of that and getting the money taken back. But there's another part that we use AI for, that we use our computers for all the time. When we get the code, so you take it from, as everybody knows, the doctor codes it. Then they send it over the clearinghouse or some way and we get to us. We process it, but then we use a clearinghouse to send it to a health plan. The health plan processes it, use a clearinghouse to send it to CMS, and CMS gets it. We have found all the way along in each one of these steps where it's a clearinghouse, a health plan, data actually gets interrupted. So whereas a doctor might submit it to us in one fashion and we get it into our system and we process it correctly, that information doesn't get to the health plan because of a clearinghouse, or the health plan changes a little bit and so it doesn't get to CMS. So we put processes in place to stop that, to validate those things. We also use AI for risk adjustment files. So when we're tracking our HCCs or we actually go back through and we try to validate and make sure that the HCC codes that are coming back from the health plans, from CMS, are what we expect. If not, we're taking tasks of that. We're trying to figure out where are the interruptions at? We compare year over year. So are we getting the same number of codes we got last year? Are we ahead of track? Are we behind the track? As we found with the V28 from the V24, we started seeing some slippage, not because the number of encounters, not because of the number of HCC codes or the diagnosis codes. It was surely because of the amount, what the codes represented, how short we were. Found out we lost a couple percentage points. So we had to work through that. Make sure that we were using our AI, make sure we were using our programs to work on those things and make sure we got them back up there. We use it in our payer for our revenue, eligibility files. We want to find exceptions. We want to find out where the health plans are not sending the codes to us, or not the codes to us, but the eligibility. Are we getting the right dollars for what we should be doing? We work with it in our cost containment. We help predict our members, which ones are high risk disease, which one will drive our utilization higher. Who do we want to get in there? Who do we want to get to the specialist to make sure that we are controlling those costs before they get out of control? We use it in the auto authorization processes. We use it in our quality improvement. So similar to the risk adjustment, we use NLP in other areas to try to find historical claims to identify the gaps in quality. And as Aruna had talked about, the holy grail in AI in this population health is the proactive care. That's where we're moving to. We're trying to identify those patients. We need to identify who needs critical care, who's going to hit the ER. Let's get ready for them. Who do we move? Who do we get into a specialist? Those types of tools we use. And you know what? We have to cover all areas of the RBO, because anything that slips through, whether we lose revenue, we lose cost containment, we don't take care of the member to the maximum level. This is what CMS is trying to accomplish with their three-legged. They're trying to control the cost, and they will control the cost, so we have to stay ahead of them. They want to make sure the member's experience is at the highest level, and we're taking care of those members. We're making sure that from all the different screenings that happen. By doing those things, we're able to stay ahead, keep the largest amount of revenue, control the costs, and make sure our profitability is as high as possible. So those are the holy grails as we need to do it.
Yeah, and from a finance perspective, having the Bloom insights and Arun, I love your term that you always use when we're talking about this, is that glass box visibility. From a CFO perspective, I'm able to ask all the questions. What is my revenue going to be in a few months? What are my costs as far as, patients, when it comes to not just revenue and costs, but together combined? How much profitability is that patient providing my specific vendor or a specific physician within my group? Incredible amount of insights. But pre and post implementation, there's not a lot of change when it comes to routine or my workflow. But Wes and Kate Tingley in the chat actually asked a great question that I think asks it better than I would have. So she's wondering about how she starts. Where would you recommend, Wes, that someone start in a workflow process or just start in general when implementing AI into their organization?
You have to figure out, to me, I figure out which area I feel is the most important. Is it the revenue side of it? Is it the eligibility, risk adjustment, claims? Those are my big things. I try to figure out from an AI perspective, I want to make sure my foundation is solid. So the first thing I do is I look at eligibility files. Are all of my members in the system appropriate? Do I make sure I'm getting paid on all of those? So we actually have a program that we use that we validate all of our members are getting in there. We make sure that they're with each doctor that they're supposed to be in our system. We make sure we receive revenue. If we're not receiving revenue, then we either get the revenue or they're not eligible with us, and we don't want to do that. My second area that I work on is my risk adjusted. So from a AI perspective, or the machine learning, or gathering up all this data, as Arun had talked to, is a risk adjustment. I want to know who my HCCs, am I getting them all year over year? What is my score? So what I do is I go through there and make sure that all of the HCCs, we try to gather year over year along with our 5-star. So putting a program into that, comparing, are you where you were last year, this year? Are you ahead or behind? Those are like 3 or 4 areas that I would start with to move forward.
Yeah, great explanation, Wes. And Arun, coming from the implementor side of Bloom and seeing, how do you want to address Kate's question?
Sorry, could you repeat the question for a minute, Jared?
Yeah, so to verbatim, her question is, given the vast opportunities for leveraging AI, where do you recommend starting, or where will the risk-bearing organizations see the most impact?
So I would certainly agree with Wes on the revenue and eligibility side, and let me elaborate on that. So, if you have your eligibility wrong, then either you may be denying claims for an eligible member, or you may be paying out claims for an ineligible member, right? So it's these things within risk-bearing organizations are all literally linked. It's not like one is different from the other. If you got the wrong claims, then you got the wrong risk adjustment, which then cycles back and gets you the wrong revenue. So it's almost a complete cycle, and you can start in any place. Certainly, revenue would be a good place, but in some cases, some risk-bearing organizations are seeing a huge cost implication. They're paying out lots of claims that they possibly that are not accurate. So some of our clients start with claims adjudication as a place to stop revenue flowing out. So there are many places you can start. Certainly, revenue and assuring revenue is a good place. Containing cost is certainly the next best place, if you will. And if you talk to clinicians within the organizations, they would possibly lean towards some form of proactive care. The interesting part of this whole thing is all of this ties back to only a few data sets. So from an implementor's perspective, that's how I look at it. I say, well, it's the client's prerogative to pick any area they want to. But from my perspective, it's these 6 or 7 data sets we need to bring together and apply our models on it. So we're happy to start with almost any area that the client picks.
Yeah, fantastic. Thank you, Arun, so much. And thank you for the other panelists for all that you've done. Arun, I want to get into your Bloom offer today for all of our panelists that are participating. What is the offer?
Jared, the intent of putting this offer together was to somewhat demystify this term AI, because it's got such a buzz. I don't know whether you watched the presidential debate yesterday, but AI was brought up in the debate also. So it's become such a hot topic that I'm sure people who are deep into risk-bearing organizations may be wondering if it is for them or it's going to make any difference to them. And that's really the intent of this offer. So basically, what we're proposing here, Jared, is that if you're a risk-bearing organization and you're looking, the question you need to ask yourself is, are you really leveraging your data to optimize your margins? That's the question. And in many cases, people may say, well, maybe I'm using my Excel, but sorry to say that, Excel is a great tool, but that isn't possibly giving you much leverage of your data. So you can pick any area that you're interested in. Bloom is we'll pay a lot of attention to security. We're a HIPAA compliant organization. We're an ISO certified organization. So should any of our webinar attendees choose to use this offer, their data is going to be safe and secure. So they provide us the data. We run a module of their interest on the data. And as an output, they get a curated and personalized report, for example, on potential opportunities for risk adjustment or the impact of V24 to V28. It can be any one of these areas that we spoke about. And we also will come back with a recommended action plan on how to implement data analytics and AI within your organization. So very quickly, that's the offer. And if people are interested, they can just send an email to our Director of Sales, Amanda Light. The email address is on there. It's amanda.l@bloomvalue.com. And she'll get back in touch and take it from there.
Okay, thank you. And thank you. Bloom has been incredibly flexible in the way that we've wanted to see our reports run, and just can't say enough about it. So thank you. And thank you to the panelists for all of your questions. And thank you for all of the ones that participated in the chat and asking your questions as well.
Yeah, thanks, Jared.
I believe there was an audience question. I saw a raised hand somewhere. I hope we got to all.
There was a raised hand. Unfortunately, we didn't get their question in the chat. So I guess we can take a moment. If you have your question still, please put that into the chat for us. As we're wrapping up now, don't forget, there's still an opportunity to set up some one-on-one time with our experts. So you can do that and I'll coordinate that. As well as after this webinar, all of the participants will be getting a recording as well as a digital toolkit that will help them with their risk adjustment programs. And if you would like to connect and collaborate with us, please reach out to Amanda Light. Her email's right there, amanda.l@bloomvalue.com. And thanks again to our panelists and all of our participants today. We appreciate your time, and we'll see you next time, hopefully. Thanks.
Thank you so much, Lauren, for hosting us.